meeting. The great team will start the meeting. So Dr. Amal, when you are ready and your team, you can go ahead.
Thank you so much, Dr. Nader. Hello, everyone. This is Amal Al-Amin. I'm going to host today's meeting on behalf of the great team. So before we begin, I just wanted to take a moment to express my gratitude for all of you taking the time to join this meeting today. Your presence is truly appreciated. So today we have 4 topics to present. Let me share my screen with you. So the topics for today are, the first one is cardiovascular diseases, part 1. And the second one, we're going to talk about the public speaking. And then we are going to talk about how to write a manuscript for a journal. And then the fourth one is how to start your personal statement. And then we are going to spare 10 minutes for projects updates. So we are going to start with the second topic, is about public speaking, presented by Dr. Rayan Hassan. And then we're going to go back to the cardiovascular diseases. So go ahead, Dr. Rayan, whenever you are ready.
Assalamu alaikum, everyone. I hope you guys are doing well. I'm just going to share my screen. Okay, my name is Dr. Rayan. I'm going to present public speaking. So I don't know if you guys noticed, but I started it off a little different. Did you notice anything? What was I not doing? Okay, so I wanted to kind of make it interactive. When I said, "Assalamu alaikum, my name is Dr. Rayan," I wasn't looking at the screen. I was touching my scarf. I was being fidgety. And so today I'm going to talk to you guys about how to public speak. We're going to look at the objectives today. We're going to see what is public speaking. How do we understand, understanding the fear of public speaking, relation of public speaking within the medical field. I'm going to give you guys tips and tricks on overcoming public speaking. And we're going to have an interactive session. So I encourage everyone to participate. Okay, so what is public speaking? Public speaking is a formal face-to-face communication method where a person uses the medium of speech to inform and or influence a group of listeners. So there's 3 things that public speaking entails. You want to inform, you want to persuade, and you want to entertain. When it comes to inform, you want to help the audience members acquire information. And so the most important characteristic is informative topics. So the goal is to gain knowledge, right? You want them to receive something that is new. And next is to persuade. You want to get the audience to make some change in their behavior or thinking. And when we speak to persuade, we want to get the listeners to embrace a point of view or to adopt a behavior that they wouldn't have done otherwise. And then to entertain, you want to have a focus on the theme and occasion of the speech. So you don't necessarily need to focus on the context or theme of the speech, but instead it requires the speaker to think about the speech primarily in terms of the audience enjoyment, right? You want to make sure that the audience is not bored. They're entertained while you're speaking. So next we have verbal versus nonverbal communication, right? Or verbal versus nonverbal public speaking. So when it comes to verbal, we have projection. Projection in the sense of your voice. So how are you projecting your voice? Next, we have the pronunciation, articulation. You want to make sure that you're using speech or words that you're able to articulate or that you're able to pronounce. When you're public speaking and you're stuttering or pronouncing words incorrectly, it almost it pushes the audience away from you. Next is the rate of speech. Are you speaking too fast? Are you speaking too slow? You want to make sure that, you know, if you need to speak fast for certain points, go ahead if you need to slow it down. So you have to gauge that. Next is their expressiveness. When I say expressiveness is the expressiveness of your speech, right? You want to engage the audience in what you're saying. And then it's the energy and tone. So when I say energy, there's different types of speech, right? I'm sure you've all had professors who speak in monotone, right? So just one way. You want to make sure that you're changing your tone. You want to have a sense of energy in your voice. Next is nonverbal communication. That's engaging eye contact. You want to have eye contact with the audience, gestures, maybe not over gesturing, but using a few gestures just to help provoke your point. Next is facial awareness, being aware of your facial expressions, and purposeful movement. So purposeful movement in the sense of, if you're presenting a topic, how are you moving? Are you only staying on like one side of the stage? Are you moving to the left? Like, you want to make sure that your movement is not stagnant. It's purposeful in the sense of engagement towards the audience. And next is your professional appearance. So your attire. Okay, so when it comes to the fear of public speaking, that is called glossophobia. So the fear of public speaking and worry of judgment from others during a speech or presentation. So a person with glossophobia will be able to function well at home, at school, and in workplace settings, as long as no one asks them to speak or present in front of others. So one-on-one is great, but once they have to get up, that's where the fear comes. And people with glossophobia regularly pursue lifestyles that don't require public speaking. So clinical presentation of glossophobia, so high stress, anxiety, panic, when a person is asked to speak in front of groups. The speaking situations almost always provoke some sort of anxious response. Social situations or situations where public speaking is expected are usually avoided or expressed with high anxiety. And the level of anxiety felt by the person does not necessarily match the threat created by the situation. And the anxious symptoms persist for 6 months or more. So the high stress and anxiety that is produced distresses that it is clinically apparent and interferes with others' areas of life. The fear, anxiety, and avoidance are not caused by the effects of substance misuse or a medical condition, and the symptoms are not better explained by another mental health disorder. So the causes, you have public speaking anxiety can be caused by environmental experiences, biological traits, and some common causes of glossophobia include inherited traits and family history. So a person is more likely to have glossophobia when a close family member has an anxiety disorder. The brain physiology, so a part of the brain called the amygdala manages a person's fear response. So when this structure is overactive, stress, anxiety, and worry will be heightened. Life experiences, so if a person has a string of negative public speaking experiences, they could begin developing the condition. And parental influence, having a parent who displays high anxiety when speaking or who are overprotective increases the risk of this. So treatments we have so you can either do CBT or medications. So within cognitive behavioral therapy, this is founded on the principle that the way a person thinks, feels, and behaves are all interconnected. So the anxious feelings can be corrected by changes to their thoughts and behaviors. Exposure therapy, this creates the desired benefits by allowing the client to confront their fears, so presenting or practicing. And then medications are benzos, beta blockers, and then you can also give them SSRIs, SNRIs, and MAO inhibitors. So public speaking in medicine. When do we need it? So it's a tool of engagement that can make an emotional or intellectual connection between a physician and their patient. So as a medical student or as a physician in the field, we tend to use public speaking a lot. So it's used in grand rounds lectures, when we're communicating with patients and fellow health professionals, medical conference presentations. A lot of doctors do television interviews. We've seen that a lot with COVID-19, and telemedicine interaction with patients and colleagues. So without you realizing it, you're using it on a daily basis as a physician. And so tips and tricks on public speaking. First, you want to practice. A lot of people would take a mirror, put a mirror in front of you, or even just record yourself. Make sure that you're not using buffer words. You don't want to use a lot of and when a person is speaking, they don't realize how much of those buffer words are being used. And so just recording yourself or just practicing in front of a mirror are great opportunities here. Again, record yourself and also keep your purpose in mind. Why am I doing this? If you're passionate about it, if you know exactly this is the purpose of my public speaking, or this is the purpose of my presentation, it also helps that you're confident, and confidence can be seen in the way you speak, right? And your audience wants you to succeed. Don't ever go in thinking like, oh, okay, I'm scared of my audience. No, the audience is there for a reason. They're there to see you, to watch you. So always consider them, as an encouragement. Okay, so we're going to do an interactive session. I want to choose 3 volunteers. If you guys can open your mic, and if you don't mind, open your cameras as well. So can I have a first volunteer?
Sure, yeah.
Yeah, so who is this, sorry?
This is Marwa Morgom speaking.
Okay, can you open your video for me? I don't know if I can see.
I did, I think, but maybe you cannot see me, but I can see
Oh, yes,
myself.
Marwa. Okay,
Yeah.
great. Okay,
Yeah.
so the interactive session is going to go like this. I'm going to give you like a topic. I'm going to give you 10 seconds to think about it. And then I want you to present it in 20 seconds, okay? And again, just keep in mind the different verbal, nonverbal texts that I introduced and spoke about during the session. Okay, so my question for you is, why did you choose the medical profession? So I'll just give you a few seconds to think about it.
But the first part, I could not hear it then.
The reason for you choosing a medical profession, like why did you choose medicine? Okay, so
Sure.
I'll give you a few seconds.
Okay. So yeah,
Okay,
I'm ready once you are ready. Yeah. So basically my journey with choosing the medicine as a specialty start from like early childhood, seeing, you know, like the animals and the illnesses and the people around me, and how like the society appreciate doctors, and they always feel like they're angels from God somehow, that relate, like they're the one that God put them to help us. Then after that, I just start to be curious about it, biology. Then after that, I took it with the like volunteer work during war. Also in my country in Libya, I start feel like, you know, go to hospital, help people, and they saw how like doctors be able actually to create miracles by helping others. And we are the one literally heal like the wounds, socially, physically. I feel like the doctors, we are the one able to do everything. So that's, you know, like may push me forward to like study hard and overcome all the obstacles. And yeah, here I am. I'm a doctor now. So yeah.
That's great. Thank you. No, I really enjoyed that. You were confident in your speech, you used gestures, your voice was very clear. I used examples. So thank you very much. Okay, I'm going to get another volunteer, please. If you guys don't volunteer, I'm just going to randomly pick someone. Okay, let's see. Tariq, are you available? No. I really encourage you guys, if there's anyone that would like to volunteer, please. Okay, Wa'il. See Wa'il Taha. Are you available? Okay, Rufayda Saleh.
Yes, I'm here.
Oh, sorry, who is this?
This is Wa'il Taha.
Okay, thanks, Wa'il. Can you open your video if you don't mind?
Yeah, give me 1 second here.
No problem. Perfect. Hi, Wa'il. Thanks for joining us. So you're muted, by the way.
Oh, sorry. Thank
Yes,
you.
no problem. So I hope you were following. So I spoke about public speaking and the use of verbal versus nonverbal communication, etc. So we're just going to do this interactive session. I'm going to give you a topic. I'm going to give you 10 seconds to think about it. And I'd like you to present it in 20 seconds. So my question for you is, what is your passion? And it doesn't necessarily need to be medicine. So just what is something you're passionate about? I want you to take 20 seconds to talk about that, but I'll give you 10 seconds just to get your thoughts all in order, okay?
I couldn't hear the question clearly. Can you repeat the question again?
Speak to me about your passion. And when I say passion, I don't necessarily mean like in medicine, but anything that you're passionate about, okay? So take some time, think about it, and hopefully you can present and share with us.
Okay. Okay, so I'm really my passion will be I'm really interested to practice medicine, and my motivation to able to more advance my career as well, and able to approach those people who in need and provide them the service they deserve, and medical service they want and they deserve. Right.
Honestly, that was great. But I need to correct you one thing, your eye contact. So you're talking to us and we receive the information, but it's more personal when you're keeping your eye contact. So next time, just make sure that you're looking at us so that we can feel that engagement. But besides that, thank you so much for participating.
Good. Thank you for your tips.
Of course, thank you. That concludes my session. Thanks, guys.
Amazing, thank you.
Thank you for that presentation.
Thank you so much, Dr. Rayan. This was a great presentation. Thank you so much.
Thank you. Oh, it was very helpful. Thank you.
So, Dr. Nader, do you have any comments?
Yeah, just this is a great presentation, and as she mentioned in the discussion of the presentation, so you're gonna do this on a daily basis when you go to residency or any other job or during the interview. So your confidence is just try to deal with the one person in front of you or people in front of you as your friends or your family that you can relate to. Sometimes it's difficult. I went through this during my first year in residency. I had to present a case and I was all over the place. So the idea is to, if you know your material, you prepare well, you will be easy. And then know that the other people might have some questions. Always there is a possibility that you might be asked a question that you don't know. Every one of us knows so much. So there is areas, or there are some areas that you don't know. So if you ask a question, let's say you are presenting a case about whatever patient that you want to present, and in the discussion there is a question and answer part. So they ask you a question about a part. If you are well
Dr. Nader, I'm very sorry to interrupt, but your voice is not very clear.
Oh, sorry.
It seems like maybe connection issue maybe.
Is that better?
Now it's clear and loud. Yes, now it's good.
Okay, yeah. So
Yeah.
I was just trying to say thank you so much for the great presentation. And on a personal level, I had this problem when I started residency. So the only thing is you can do is you can prepare for your presentation, let's say a case presentation or during the session. There might be some questions that you don't know. If you have a question that you don't know, just tell the truth or be honest. Tell them, I don't know the question, the answer for this question, but it's an interesting question. I'll find out, and next time you meet them, you can relate the answers to the question. So feel at ease that no one will have all the answers. So don't be shy because of that. So you're gonna be fine. Thank you.
Thank you so much, Dr. Nader. So do you have any questions for Dr. Rayan before we proceed to the next topic? Okay, so our next topic is going to be about cardiovascular diseases, the first part of it, presented by Dr. Aiesha. Go ahead, Dr. Aiesha.
Assalamu alaikum, everyone. Can everyone hear me? Okay.
Yes, we can hear you clearly.
Okay. Can everyone see my screen?
Yes.
Yep.
Okay. So, Assalamu alaikum, everyone. My name is Aiesha Usmani, and I'll be presenting the first quarter of cardiovascular diseases and disorders. So our objectives for understanding this first is to know and understand how the cardiovascular system changes with normal aging, the signs and symptoms of the most important cardiovascular diseases in older patients, the appropriate diagnostic tests to identify the presence and severity of CVD, and the standards for treating CVD. So the topics that will be covered are epidemiology, the effects of aging on cardiovascular function, cardiovascular risk factors, coronary artery disease, acute coronary syndromes, chronic coronary artery disease, valvular heart disease, cardiac arrhythmias, peripheral arterial disease, and venous thromboembolic disease. So to start off with the epidemiology, so among 870,000 deaths in the US are from cardiac and cerebrovascular diseases. So 84% occurred in adults 65 years and older, and 68% occurred in the 6.1% of the population at least 75 years of age and older. So with the aging of the population, the absolute number of cardiovascular deaths in older adults is expected to increase markedly over the next several decades. And this chart here reflects that. So the prevalence of CVD increases progressively with age, exceeding 80% in men and 90% in women 80 years and above. So there are also a lot of effects associated with increasing age. So for example, as we increase our age, our arterial stiffness also increases. And the consequences of that can be an increase in afterload and systolic blood pressure. However, we also have a decrease in myocardial relaxation and compliance. So the consequences of that include the risk of a diastolic heart failure and atrial fibrillation increasing. We also have impaired responsiveness to beta adrenergic stimulation. And as a result, the maximum cardiac output and impaired thermoregulation are also decreased. Sinus node function and conduction velocity in the atrioventricular node and infranodal conduction system decrease with age. However, the risk of sick sinus syndrome, left anterior fascicular block, and bundled branch block increase as well. To continue off of that, we have increased impaired endothelium-dependent vasodilation with increasing age. And we also have a greater demand ischemia and risk of coronary artery disease and peripheral arterial disease as well. We have a decrease in baroreceptor responsiveness with increasing age, and the outcome of that is also an increased risk of orthostatic hypotension. However, we have a decrease in exercise response, meaning lower maximal heart rate, maximal cardiac output, VO2 max, coronary blood flow, and peripheral vasodilation. This results in a decrease in exercise capacity and an increase in cardiac complications, which encapsulate ischemia, heart failure, shock, arrhythmias, and death with illness. So some of the clinical effects of CV changes include that in healthy older adults, age-related changes have modest clinically relevant effects on cardiac hemodynamics and performance at rest. So to continue, the resting heart rate, ejection fraction, stroke volume, and cardiac output are well preserved even at very advanced age. And the ability to respond to increased demands associated with exercise or illness, either cardiac or non-cardiac, declines progressively with advancing age. Peak aerobic capacity, as assessed by maximal oxygen consumption, also declines inexorably with age. So this also has changes in our organ systems. So to start off with the renal system, the age-related changes in that are a decrease in GFR, a decrease in concentrating and diluting ability, and impaired electrolyte homeostasis. So the impact of that is volume overload with increased fluid intake, dehydration with decreased, increasing risk of electrolyte disturbances, and increased risk of worsened outcome in patients with CVD. For the pulmonary system, the age-related changes include decrease in vital capacity and an increase in ventilation perfusion mismatching. However, for the clinical impact of this, there is a decrease in pulmonary reserve and increased dyspnea on exertion and decreased exercise tolerance. For our neurologic system, we have a decrease in autoregulatory capacity, altered reflex responsiveness, and impaired thirst mechanism. And as a result, excuse me, let me change this. As a result, we have impaired cerebral perfusion, increased risk of orthostatic hypotension, and increased risk of falls, and an increased risk of dehydration. Oh, sorry. And for our musculoskeletal system, we have osteopenia, joint stiffness, and sarcopenia as a result of increasing age. And the consequences of this include a decrease in exercise capacity and increased risk of falls. And then for our hematologic system, we have an altered balance between thrombosis and fibrinolysis. The impact of this is increased risk of arterial stroke, arterial, which includes stroke and MI, and venous, which is pulmonary embolism and deep vein thrombosis. We also have an increased risk of hemorrhage with antiplatelet, anticoagulant, or fibrinolytic therapy. And lastly, for our GI system, the age-related change observed is the altered absorption and elimination of drugs, altered hepatic metabolism of drugs. And the impact of this is increased risk of adverse drug interactions and adverse events from cardiovascular and non-cardiovascular medications. So there are also certain risk factors involved in CV. So 4 major risk factors include hypertension, diabetes mellitus, dyslipidemia, and smoking. High rates of CV disease in older people is the absolute number of cases per risk factors tend to increase with age. Multiple risk factors act in concert with age-related CV changes to promote the development and progression of heart and vascular disorders. So hypertension, basically systolic BP tends to increase gradually with age, while diastolic BP peaks and plateaus in late middle age and declines thereafter. Pulse pressure, which is a difference between a systolic and diastolic blood pressure, increases with age, and isolated systolic hypertension becomes the dominant form of hypertension in older adults, especially women. Although the prevalence of diastolic hypertension declines with age, the presence of increased diastolic blood pressure raises cardiovascular disease risk independent of systolic blood pressure, particularly in men. Diabetes mellitus, the prevalence increases with age of at least up to age 80. So approximately 50% of patients with diabetes in the US are at least 65 years of age and older. So as in younger patients, the impact of diabetes on cardiovascular disease risk is greater in older women than in older men. And this was observed in the Framingham Heart Study. So they saw that the adjusted risk for incident coronary heart disease for older patients with diabetes was 2.1 in women and 1.4 in men. The excess risk associated with diabetes was greater in both men and women, 65 years of age and older, than in younger individuals. Dyslipidemia is also a risk factor. The strength of the association between total cholesterol and LDL cholesterol levels and incident CAD decreases with age, especially after age 80. But low HDL cholesterol levels and high ratios of total cholesterol to HDL cholesterol remain independently associated with coronary events, even among people above 80 years of age. So clinical trials have demonstrated benefits of statin therapy in moderate risk and high risk patients up to 85 years of age. Smoking is also really big a risk factor. So the prevalence of smoking declines with age, particularly due to successful smoking cessation, partly due to premature deaths in smokers. So among older smokers, smoking cessation is associated with substantial reductions in cardiovascular disease risk within 2 to 6 years relative to continued smoking. In most studies, smoking remains a strong and independent risk factor for fatal and non-fatal cardiovascular disease events among older adults. Some additional risk factors include whether the following are important risk factors for CVD among older adults is unclear. So other factors that we must include are obesity, increased levels of C-reactive protein, fibrinogen, D-dimer, and plasmin antiplasmin complex. And the coronary artery calcium content on CT is also a major additional risk factor. So that's that. Thank you so much, everyone, for listening.
Should we go for the part 2 or?
Yes, go ahead, Dr. Marwa, for your part, please.
Thank you. Sure. Thank you so much. So 1 second, just let me make it full screen. Okay, invite this one. Right, no issues. So I'm Dr. Marwa. I'm one of the newcomer actually to this program, and basically what I will mention is the continuation of what Dr. Aiesha started. So my topic is really short, and I'm not kind of person I really enjoy to put a lot of like information in the slides. So I just cut off most of the information. So it will be most of the time like me talking about like the main point I want to basically introduce to all of you guys and discuss together, of course. This is the objective. So as I mentioned, it will be just acute coronary syndromes versus chronic coronary syndromes. Acute coronary syndrome, of course, with all the types we know, stable angina versus unstable and, of course, myocardial infarction. So yeah, so those main points, I believe all of you have good info about it. So we will just try to make it interactive as much as we could. Of course, I have no conflict of interest. Epidemiology, I believe also Dr. Aiesha, she mentioned that very well. So I'll just try to highlight it again very quick. So basically in epidemiology regarding this topic, we know that the mortality acute, like MI in general or acute coronary syndrome start increasing, and most likely it's related to the comorbidity it's in our society and lifestyle actually we practice nowadays. So we know that it's most of the time it's basically the disease of old, or that's how we describe it. Most of our population, like most of our patient will be the patient in age like 65, 60, those kind of patients, they will came to you with whatever was the type of coronary artery syndrome. And most of them actually can present to you with silent MI. And especially with increasing in the age, of course, because the diabetes and hypertension affect on, our sensation in the nerve system. So the patient, he may had silent MI actually, and we discover it later. All right. So as I mentioned, just to refresh our knowledge about it, what types of acute coronary syndrome we are talking about it. We had unstable angina or non-ST elevated MI. We had ST elevated MI. And also we have the stable angina pectoris. The main difference is only the time or the duration of the incident and how much occlusion of the coronary artery and how much the blood will be cut off from the cardiac muscles and the time frame. And that will change totally the presentation and also will change the diagnosis we will give or we label our patient with it. The image here will show it actually. Of course, we all worried about the ST elevated MI because the major damage will happen to basically the muscles and the cardiac muscles if the doctor not intervene in the right time. Because, with the lifestyle and all the risk factors Dr. Aiesha mentioned, we will start having atherosclerosis, fibroscap, plaque with atheroma, and all of that we studied in the med school. Then after that, start increasing. If increasing gradually without rupture and there is still patency in our vessels, that's what will give a stable angina. If we put our body at point that we overuse like stress or exercise, we are not tolerated to it, it may switch from stable to unstable or non-ST elevated MI. And if the patient not lucky, maybe ruptured and completely occluded for the vessel or coronary artery, and he or she will show up with ST elevated MI. And this is the step we try to avoid. Right. The interesting part for acute coronary syndrome, actually, and from Dr. from my background in residency in emergency medicine, the presentation of acute coronary syndrome, it's quite vague. Most of the patients, they will not, in the books, they will mention like typical chest pain, radiating to the jaw, radiating to the left shoulder. But in reality, you will find that that's not that accurate, especially when women, they always present with atypical chest pain. When also your patient, he's old, you don't expect that he will mention chest pain. Sometimes they don't have a chest pain. He will came confused, or he came with shortness of breath, just a sweating, or he will prescribe to you symptoms little bit vague. Some of them epigastric pain, some of them they came with GIT symptoms actually. In those cases, we needed to have always a threshold to investigate and suspect acute coronary syndrome, especially in women and old age patients and patients with high risk, of course. So presentation, as we mentioned, the messages could be anything. So we needed to investigate, and ECG at time you saw patient, and you needed to repeat it, not only one. It will be serial ECGs, because most of the cases they will have normal ECG in the first 1 or 2 hours. So it changes like blood result, it will take time. So you needed to pick up that when changes will happen. Right. So once you suspect patient came to, like you saw patient and you saw it in the office, you saw it in the ER. Once you saw this patient and you suspect the presentation, maybe one of my differential will be acute coronary syndrome, you should give this patient actually aspirin, 325, regardless of the age. If patient cannot take orally, you may give it rectally. Oxygen we give, but the last research mentioned that if patient can maintain his oxygen status above 90, we don't give oxygen, because oxygen consider also have increase actually ischemia somehow to the cardiac muscles. So oxygen only if patient was gasping for air and he had low saturation. Rather than that, don't put patient on oxygen. Analgesia and morphine, all we know that it will help actually somehow. There is vasodilator effect for the morphine. Also it will be an anxiolytic, decrease the anxiety for this patient. IV nitroglycerin with the same idea of sublingual, whatever we had around that time. Also, it will be really effective to release the pain for this patient until we reach to the diagnosis and provide the definitive treatment. Right. This is just, I want to highlight regard the cardiac exam when we send actually in. We send, in like in the office or whatever, like the place you're seeing your patient. Most of us, we will send for the troponin I or troponin T. And this is the time frame where CKMB or total CK or troponin will raising in the blood. The message I want to send, if you saw patient clinically, he looks like he may have major incidence or acute coronary syndrome. This patient have high risk. He had hypertensive, he is a smoker, alcoholic, obese, lifestyle like office job or whatever, you feel like there is a lot of risk factor, diabetic, and the presentation was vague and you have no idea what this patient had. You did the first ECG was normal, you send the first set, the troponin is normal, still you cannot rule out acute coronary syndrome. You need to send second set, you need to do serial ECG, you need to do a bedside echo or even official echo, depend on, and don't be shy to consult cardiology as soon as you suspect this diagnosis, because this is life changing actually. High mortality rate if we do not intervene. Here, I just want to mention what option we have basically in treatment for acute coronary syndrome. Wherever we talk about stable angina or unstable or even still elevated MI with different, of course, stages, different medication. First of all, let's agree that all of them, they will receive aspirin unless there is contraindication like anaphylactic reaction for aspirin, for instance. So we can switch it with something else like clopidogrel. Some they give double antiplatelet, but only we give that if this patient will end up in BCI within the next 24 hours. Some they prefer to give aspirin with low molecular weight heparin, inoxa and deltaparine. I saw that a lot actually in the practice in some hospitals. Some they will be worried about adrenal function because, as we mentioned, we deal most of the time with old aged patient with a lot of comorbidity. So we assume that he will not have a proper renal function. So we know that some types of heparin, low molecular heparin at certain GFR, we cannot give it. So from there, they start thinking about it, other medication like bivalirudin or fondaparinux and etc. Some of them use it, depend on the approach the doctor actually using. All of them show benefit. And all of them, we will use it just to prevent progression of the thrombus. It's basically started in the coronary artery until we provide the definitive treatment for this patient. If you suspect your patient had ST elevated MI, Here, we will have what we call it the golden hour. Within 6 hours, if there is cath lab in the hospital where you are working, your patient, he need to have BCI to just reperfuse basically the cardiac muscle. If there is no BCI and in the hospital, there is no cath lab, or you cannot provide the BCI, and you cannot shift the patient to another hospital in the proper time within 6 hours, some say like 90 minutes, or 120 minutes. So the other option will be fibrinolytic agent. So you will thrombolize this patient unless there is contraindication of thrombolysis. Contraindication in this case, it's the same contraindication of use of thrombolysis in the stroke. So it will be the same thing when we cannot use it. There is relative and there is absolute contraindication. And always keep in mind that the patient you are dealing with is old age with a lot of comorbidity, with high susceptibility to bleed. So this patient, you will have it like full package. He had a lot of comorbidity, and the chances that he will bleed from the medication you are giving to this patient is high. So we always prefer to go BCI unless there is, of course, no facility available for the BCI. And of course, BCI, the outcome is superior when compared to the fibrinolysis or thrombolysis, because the risk factor we have from these medications. So depending on the availability, we had it in our hospital, of course. Right. Basically, after that, we talk about it, all this medication. Yeah, we talk about it, the BCI. Later on, I will mention what's the difference between BCI and when we will do the bypass, what's the indication and which one is superior, and when we will do when we will decide which one we will go for it. I just want to highlight this topic. It's really big, and there is no way actually that I can present it like in 20 minutes or so. This topic actually needs 4 or 5 lectures. So I just try to take like a major point. I feel like it's really important from each topic, and at least, like refresh our knowledge about it. One of the things I felt like we needed to mention, just guys, see your skills in the ECG. So anyone volunteer to tell me what this ECG represents? And I'm sure most of you know what's that, just, as a refreshing. So it will not be boring lectures. Any volunteers? Anyone can tell us what this ECG represents, guys? Should I pick by myself, guys, or I can pick my favorite letter, maybe? Anyone he feel like he's confident to talk about this ECG, guys?
Yes, Dr. Marwa, I'm not sure, but I'm gonna try. I can see like ST depression in the V1.
Okay. Excellent.
And the lead below it, is it V3?
Yeah, V2, V3. Yeah. So what?
V4.
Yeah. So what you think? We are dealing with what?
Yeah, this is maybe acute coronary syndrome. Is a non-ST segment elevation.
Basically, yeah, basically this is ST elevated MI, but the thing is this is posterior MI. And this is a quite common confused ECG, like we always confuse it. So if you change the leads for this patient, what we call it right V7 or right V8, and just you put it in the right side, you will see the ST changes because you will basically present the posterior wall of the heart. So this is one of the ST elevated, even though you see ST depression, but if you change the position of the leads, you will see it as ST elevation. So this is basically required BCI. This is posterior elevated MI. Amazing effort, doctor. Thank you so much. And this one. What's tombstone sign, guys? Anyone?
Hello?
Yes.
Like something widow something?
No. I will tell you like the history. Basically, old-aged man, he came to you at 3 a.m. You are the unlucky doctor who was in shift at that time at 3 a.m. and he came sleeping, just breathing air. You open his file and you find that he had diabetic hypertension. He had extensive history of smoking. He's not taken his medication for a very long time.
And teacher, what am I?
Yes,
This
exactly.
is expensive. This is
Extensive
LED
actually,
occlusion.
Yes.
My
This,
the somber
yeah,
sign, it's a grave
yeah,
sign, as they say.
exactly. Yes.
Yeah, indicates a very severe form.
Exactly. This one, if you did not basically act fast, he will end up in grave, literally. That's why they call it this name. And I found it interesting. This ECG and this ECG is a tricky, actually. What do you think, guys? It's really easy one, but I spent like 30 minutes to try to figure out what I'm looking for. So I bought it to be, I'm sorry, I just bought it to give you a hard time, guys.
Inferior lateral MI.
Actually, this is pericarditis. If you can see the concave smiley shape, lead 2, 3, and actually in V5 and V4, almost all the leads. So this is pericarditis. Also me, at the first I was like, this is inferior MI. But if guys, you see this shape, smiley face, it will never be MI. This is actually a good sign. This is pericarditis. Last two, then after that, yeah. What do you think the first one up, the one I'm pointing, this one? You just said it, doctor, I think. This is inferior MI. You just mentioned
It's inferior.
Yeah, you can see how the there
Inferior
was
lateral.
Exactly. Yeah, even lateral. Yeah, I agree with you. You can say within this AVR and all of that. Yeah, the AVL. Yeah, it's inferior lateral wall actually. Also here it's almost the same. Here inferior and here inferior lateral. Amazing. Thank you, guys. So coming back to talking about acute coronary syndrome, we know that all our patients, if we diagnose, we did the BCI, or we decide only to do like thrombolysis, or basically it was unstable angina and there was no need for BCI at the moment. Most of our patients, they will be admitted under the medical floor. Cardiology, they will follow up with those patients. We will see those patients in the morning rounds. And there is medication, we need to start patient on them unless there is, of course, contraindication, because they will decrease the remodeling of the cardiac muscles. They will improve the mortality, the prognosis, and decrease the mortality rate. Of course, we know all of us that we need to start them in beta blocker or calcium channel blocker if there is contraindication of the beta blocker, ACE inhibitor, or prove that improves survival on those patients. Statin, clopidogrel also, we can start it, depend on the age and depend on there is contraindication or no. Especially patient with the BCI, they will stay up to 1 year actually in double actually antiplatelet. You will find them on aspirin, clopidogrel, some of them like up to 9 months, some of them up to 1 year, depend on assessment of the cardiologist around that time. Always keep in mind, if patient went through event of acute coronary syndrome, you will see this patient again with symptoms, looks like acute coronary syndrome. Within 1 week, he will come again to you. After discharge, he will be panicking and he will have what we call it actually psychological trauma. This patient always, whatever he felt, he will believe, oh my God, I will die. I'm having the same attack. And they saw that a lot. And the issue here is when this patient been admitted, no one assessed him psychologically. No one explained to him. No one did proper rehabilitation. And I believe this is really important part of treatment for those patients. And that's actually part of reduce the mortality. I mean, in the research, they mentioned that one, we improve the emotional behavior and the thinking of patient about their illnesses, and they have well understanding, mortality rate for those patients will be reduced within 30%, which is a huge number actually. So we always keep in mind, try to talk to your patient, try to tell them like what they will expect. Also, we have a Dressler syndrome. Some of them, they will end up with pericarditis after it. If you did the proper reperfusion, your patient, he will have arrhythmia, sometimes AF. There is a lot of possibility here, and you needed to expose your patient to all of these events may happen with him. So he will be prepared mentally and emotionally. Just to recap, as an ACS, we divided actually, we said the chest pain, shortness of breath, or confusion, depending on the age, depending on the gender also, how the patient will present. Then after that, we will do the ECG, can guide us. What we will see is there is ST elevation on you, left bundle branch block. Then after that, okay, maybe my patient actually had ST elevated MI. Then we have Brugada, we have Scarborough actually criteria and modified one. I will not talk about it here. Troponin positive for this patient, okay, or ECG was significant and you have a previous ECG to compare and was normal, so there is no time to waste. This is ST elevated MI, you need to act now. BCI or thrombolysis, cardiology need to be involved. If a chest pain with ST depression, T-wave inversion, you did serial ECGs, no new changes rather than the changes you saw the first time. Troponin still negative, and you repeat it within basically 6 hours. The first set and the second set still negative. Okay, this is unstable angina, and the history actually will be clear. The patient will mention it. Before, when I was doing any exertion, I feel pain. Once I rest, I feel okay. But recently, this shortness of breath start increasing even with minimal exertion, and now I have it when I'm resting. This is unstable angina with a troponin negative. If a troponin positive, this is non-ST elevated MI. Some doctors, they mention a non-ST elevated MI, we need BCI, but there is no urgency to do it immediately. Some of them, they do it after 24 hours or even longer. It will be more diagnostic actually. And you will keep the patient on heparin, you keep them on antiplatelet and all medication we mentioned, right? Last topic we will mention very quick is chronic coronary artery disease. It's almost the same. We talk about it, all the risk factors. The Dr. Aiesha, she did an excellent job, mentioned all the risk factors we needed to keep in mind when dealing with our patient. So chronic coronary artery disease, it's a disease of elderly most of the time, because it will be just buildup of atherosclerosis, buildup of like the sickness in the vessel. It will be just build up within time. So your patient, he will come with symptom gradually. Older patient, they will come to you, they will have it more. They will have a claudication, they will have shortness of breath, decreased daily activity, and you will see it gradually. Most of them, they will have a triple vessel actually, and some of them, they will have left main coronary artery disease, whatever was the occlusion. Some of them, they have it as acute at the beginning. They came to you with MI or non-ST elevated, we treat that, but eventually they end up with the chronicity of this illnesses. Some of them, they will never came back to the baseline, but we tried just to improve their lifestyle and basically decrease the complication. Some of them, they may end up in left ventricular and heart basically failure and left ventricular dysfunction. You will find them on double and triple actually diuretic, depend on how much necrosis and damage happened to the coronary artery, reflect coronary artery on the ventricles, especially the left ventricles. So it's quite serious, and I believe it's topic worth more than one lecture to talk about it. As diagnosis, older adults, as I mentioned, this is disease of all elderly most of the time. So the elderly, the false positive rate, like if you did a stress test, it will to diagnose the chronic coronary artery disease, it will be lower on compared with the young. And that's really interesting actually finding. In young people, when you do coronary when you do stress test, sometimes it will give you false positive, and it happened a lot actually. Whatever was the other illnesses the young gentleman or the young lady had it, we will believe like, oh, maybe he had coronary artery disease, but it is just false positive with other differential diagnosis. But in adults, if stress test, an old adult, if stress test is positive, 90% definitely he had coronary artery disease, because as we mentioned, this is a disease of elderly, and it requires time actually and a lot of risk factor to build up. Right. This is the same. I will not go a lot. I will not explain it a lot. The same thing, just we have target. We mentioned our risk factors: diabetes, hypertension, hyperlipidemia. So the aim is to educate your patient. If you are a primary care physician or you are hospitalist, whatever was your place, it's your duty to explain to your patient what's the aim, how can actually prevent this event, and how can decrease the complication after the event is happening. Always take care about it, the hyperlipidemia, what's the target of the LDL we needed. The strict diet the patient needed. If he's a smoker, we need to quit smoking and explain the damage smoke can cause to the heart, the type of the diet this patient needed, how much the aerobic exercise, even just walking for like 30 minutes, 3 days in the week, how much effect, good effect and a good impact had it in the heart. Always talk to your patient, and you will be surprised how much of them they don't even know about it. No one explain it, and you will be the first one actually explain it to them. Right. Here, almost the same. I will not go much explain it. I mentioned it, actually, all of it. We mentioned calcium channel blocker. We mentioned all of it as medication. This patient will be discharged on all these medication: anti-lipid, antihypertensive if he's hypertensive patient, beta blocker or calcium, control his diabetes. We also put them in anti-anginal medication. Some of them we keep them in sublingual or spray, basically GTN or isosorbate mononitrate as a long-acting. Also, some of patients you will find them in ranolazine. Also the same thing. It's anti-anginal medication, and it's really good and improve even the patient movement. Patient will tell you that I feel like I'm now be able to do more exercise. I have more exercise tolerance. The pain will not come the same low threshold they had it before. This medication is really good, and patient actually ask it and prefer it. Last slide, I have it, the revascularization. We mentioned about it, the BCI, and we mentioned about it, the triple bypass, basically, or the whatever was the surgery and the stent most of the doctors do. Just I want to highlight that BCI, it's actually both of them, BCI and bypass surgery, in the long term have the same, the similar outcome, the similar prognosis, the similar almost reduce in the mortality in the long term. If someone mentioned bypass is better, that's not true. Both of them the same. The only differences is bypass surgery, actually you will expose your patient. Of course, some patient will need it. I mean, it's the cardiologist's decision, depending on how many artery involved. If it's 3, he will go for it. And there is actually criteria for bypass surgery. If your patient fit the criteria, he will go for it. But the issue with bypass surgery that, again, you're dealing with the fragile patient. Bypass surgery, after the patient needed at least to be in the hospital for 2 weeks. This patient, he will be exposed to delirium. He will be exposed to the UTI. He will be exposed to risk of rebleeding. You will see a lot of changes in this patient, depression. So he will be in vicious cycle of a lot of issues we can avoid with the BCI. If there is basically like we needed to choose between both of them, and both of them we can use. BCI, it's better. The discharge for this patient will be earlier, so we can avoid a lot of complication we saw the patient had with the bypass surgery. Right, I just mentioned all of it actually. So yeah, the functional decline, the delirium, always remember that our patients, especially the coronary artery, most of them old age, most of them are fragile, most of them, I mean, the threshold for having delirium, for have UTI, for have functional decline, to have acquired infection, it's really low. So as much as we could, and DVT and all of that, as much as we could, we should like choose the least invasive procedure for our patient and try to discharge them safely to rehabilitation center. We try to give them as OBD appointment, of course, cardiac rehabilitation program, right? Again, I will just point cardiac rehabilitation. It's really important. Talk to your patient, explain why that happened to him, what's the risk factor, what he can do to prevent it. And like in other places, actually, there is a closed meeting for patients have the same illnesses. They will talk about it, try to explain, ask him always to like go with the follow-up in time, long-term care, keep the medication, all of that. Thank you so much. Thank you. Any question, guys? Anything?
Thank you so much, Dr. Aiesha and Dr. Marwa. This was a very nice presentation. I personally enjoyed your presentation very much, as I'm working in the emergency department. And I want to emphasize the fact that, yes, patients do present with atypical presentation for myocardial infarction very frequently. I had a 65-year-old diabetic man presenting with only shortness of breath. So at first, like I couldn't imagine, I couldn't put in my mind that this could be myocardial infarction. It should be something with the lungs, like asthma, anything else. But then I told myself, he's an elderly man, why not doing, and he has risk factors like diabetes, why not doing an ECG? So at first, ECG showed non-specific signs like ST segment depression, and it was not concluded of myocardial infarction. And then when we repeat the ECG 1 hour later, it showed like extensive inferior wall myocardial infarction And unfortunately, the patient ended up with cardiogenic shock and we couldn't save him. So yes, this could be very severe and we have to keep eyes on those patients. Thank you so much.
Thank you so much, guys. Thank you.
So do you have any questions?
Guys, if no question, that means even you hate it or you understand it all. So I'm not sure which one.
No, it means that you explained it in a very nice way.
Yes, I have a
Thank you so
question,
much.
please.
Yes.
You said that at the first ECG, is it an anterior posterior lead, you said?
Sorry, which one? Let me just,
The first ECG you present, ECG.
sure. Yeah, let me just go for it. This one, yeah? This is
Yes,
the first one I
yes,
said. Yeah.
yes.
This is basically posterior. Maybe you will be surprised later. You will find it AVL also involved with it, even though I cannot say clearly here. It's
yes.
actually lateral, but it's more posterior clear V2, V3. To confirm, always I advise any patient you have suspect like in V2, V3 or V2, V3 and V4, but mainly V2, V3, always do what we call it right leads. Right leads will show you the posterior of the heart. So if there is any changes, you will see it at the ST elevation. And those patients need BCI and thrombolysis, depending on what you have in the hospital.
Yes, I want to know if there is any way you can tell that this is an anterior or posterior lead from the ECG only, or I need someone to tell me that this lead is posterior.
Well, basically, if you saw, the rule is, if you saw a ST depression, significant one in V2 and V3, this is posterior. But to confirm it, you needed to ask the nurse to change the chest leads, the V7, V8, just to, sorry, 6 and 7, just to switch it and put it a little bit in the right mid-axillary line.
Yes.
When the nurse will provide it to you, she will write it's R, which is right, R V7, R V8, for instance.
Okay.
Which is meaning this is the right leads. All
yes,
the nurses they do
this
that.
Is my question exactly. This is the answer.
Yeah.
For my
So
question.
the nurse should do that. Actually, they do that if they are trained well, of course, and if the nurse not hate you. So yeah.
Thank you so much.
Thank you. I should take care.
Dr. Marwa, I have a question regarding the ECG. Sure. Just the one ECG you showed. Is this sinus bradycardia or
which one for
some
this
form
one?
Of heart? Yeah, for this ECG.
Yeah. So basically, for this ECG, I can see the B waves here, but it's really small, to be honest. So in those kind of patient, you can see any type of arrhythmia, but still, I will go that he had actually sinus bradycardia. This patient, I believe he's in a pre-arrest stage. He had sinus brady with posterior ECG changes, but I cannot see. I mean, the QRS somehow is still not that narrow to say like it's ventricular rhythm. Of course, I will need another ECG to confirm, but it's not that wide to say like it's ventricular. Could be sinus brady, that's why the B wave is not clear. Could be early ventricular rhythm with the MI, and that's also possibility, especially in the posterior. Some people, when you have the posterior, actually AV node will be affected. So maybe it's ventricular, but the QRS is still not that wide to confirm. So I would love to repeat the ECG. Don't be shy to ask to repeat ECG once and twice and 3 times. The nurse will hate you, but the patient will like you. So always ask to repeat ECG in a while, and you will see the changes with it. So you will be 100% sure about what you are dealing with.
Yes, I agree with you. Actually, nurses will hate you a lot, but you should pay attention to the patient. Thank you so much, Dr. Marwa.
Thank you, guys. Thank you.
Thank you. So, thanks, both of you.
Thank you so much, Dr. Aiesha and Dr. Marwa, for the great presentation. So our third topic is going to be presented by Dr. Suhir and Dr. Abdelwahab, and they are going to talk about how to write a manuscript for a journal. Please go ahead, Dr. Suhir.
Hello, good afternoon, everyone. Can you hear me well?
Yes, your voice is very clear.
Okay, great. I'm trying to share my screen. And please let me know if you can see it. Okay, is it clear?
Yes.
Okay, great. So, good afternoon, everyone. My name is Suhir Abdelwahab, and today my colleague Rahman Abdelwahab and I, we're going to present to you a topic about manuscript writing. And did you know that last year about 65% of medical graduates didn't know what manuscript is? That's interesting, right? Well, I'm just joking. This is not true. I made this number because in my research, I didn't find it. But the truth is many people don't know what manuscript is, specifically the scientific one. So in our presentation today, we'll try to shed light on that and explain what it is and how to do it. So essentially, the idea is as a researcher, you have ideas, questions, or theories in your head, and you want to write them down in notes. And in this way, you're transferring from stage of ideas to stage of draft. And then this draft is going to be exposed to different levels of revisions and rewriting and refinement till you reach the final stage of transferring it to a manuscript. So what is a manuscript? When we say manuscript, we mean that it is the document that you submit for publication. So in other words, it is the author's text that has not been published yet. And traditionally, the name manuscript used to be referring to anything that is written by hand as opposed to typed in a computer electronically. So it can be a book, a document, or even a piece of music. But for the purpose of presentation, we'll be focusing on scientific manuscripts, come in different types like original article manuscripts, or reviews being a simple review or of literature or systematic review, or even editorial, etc. So if your manuscript is reviewed, submitted, and also accepted for publication, then the name of the piece will be changed into an article. I hope this clarifies what we mean by a scientific manuscripts. So before writing our manuscript, there are certain steps or stages that we have to be sure that they are already completed, such as the data collection and the data analysis and the presentation of data in visualized forms such as tables and figures, and having our clear objectives covering a central 2 or 3 ideas maximum. So different scientific manuscripts agree that they have a specific order in which they are written, and the order starts with presenting the methods that were used to conduct the research, and then the results that obtained from the research. After that, you follow it by an introduction, a discussion, and abstract. And we will be discussing each of these elements in detail. But generally, different scientific journals, specifically medical journals, have a common format called the IMRAD that they require the researchers to present their manuscripts in. And to give you a little idea about it, the IMRAD stands for, the I stands for introduction. And here, present to a reader what prompted you to start your research. Where did you get the idea from? What was you thinking about?
Suhir,
And
can I
also
interrupt
to
you?
add. Yes, please.
I think, can you unshare your screen and then share the screen that you are presenting, because we are on the PowerPoint 5, not the presentation 5. We are not following the same.
Oh,
We
okay.
are on the page 1.
Okay, so I'll stop sharing and sharing again. Right. Okay. Okay, so is it viewable now?
Noted.
No, not yet.
I'm sorry,
we
I don't
can't
know.
see it now. I think it may be
You can
less
see
in
it
the
now?
internet. Now we can see, yeah.
Yes.
Okay, great. So should I start from the beginning or?
We're still seeing the PowerPoint, the slide, and on the left side, the slide numbers. So it's not the presenter mode.
That's weird because in my screen it's on presenter mode and it's full screen.
You can
So
move the slides.
Just make it full screen.
Yeah, now it's
Okay.
moving.
It's full screen on my screen, so I'm not sure what to do.
Let me share your presentation for you, if that's okay.
Okay. Yeah, sure, works.
Yeah, so please unshare so I can share my screen.
Cool. I stopped sharing now. Actually, it's the third one, the scientific manuscript.
Okay, sorry for that.
Okay, thank you.
You're welcome.
Okay, so I think we can move from this slide to the next. Okay, so like we said, manuscript refers to the author's text that is willing to be presented to a scientific journal for publication. And for scientific manuscripts, we have different types. They could be original article or review, a simple review or systematic review or critical review or editorial. So this manuscript will be reviewed and will be submitted for the journal. If it gets accepted for publication, then it will be called an article. Okay, next slide, please. So as we mentioned, before submitting the article, we have to make sure that we are done with our data collection and analysis and presentation of the data and having everything clear, including our objectives, setting it to 2 or 3 ideas maximum. Okay, and here's the order in which you write your manuscript, starting from the methods, followed by the results of your experiment. And sorry, when I say experiment, I don't mean like a clinical trial, generally your research experience. And after that, we'll be talking about the introduction, and you will discuss what you came with in your results and how they compare to the existing body of knowledge, and lastly, the abstract. Next, please. Okay, so the IMRAD format is an agreed upon between different scientific journals on how you, these are the important elements that you have to have in your manuscript when you present it for publication. So the first one is the I standing for introduction. And at this point, you have to talk or write about why did you start this research? What prompted you? The ideas or the theories or the things that you were thinking about to add to the scientific knowledge. M stands for the methods. You have to explain what did you do, what methods did you use, why did you use them, how you came up with them. And R, of course, for the results, you have to talk about what the findings of your research, being producing a new knowledge or reinforcing an existing evidence, or even trying to contradict something that is already present with your evidence. And the last thing is the D, it's for discussion. So here in this point, you have to explain what does that all mean, what you came with, and how does it interpret into the reality and on the medical experience for yourself and for others. Next, please. Okay, so as we can see in this slide, this is display of the different sections that a manuscript should contain. We will talk about each one of them in a little detail, starting from the title page, and we'll talk about the author affiliations, the abstract, and then the piece of introduction, followed by the materials and methods used, the results and discussions. And after that, we'll talk about the acknowledgements on funding and the references, and lastly, the tables. So next, please. Okay, so the first page will be the title page, and of course it needs to be a clear title and attention grabbing, because this is the first thing that people see in the article. The wording has to be a few words that can describe the content of the paper, and often the types of studies, the epidemiological study used would be indicated in the title page. And also it's very important that the title page includes the author affiliations, the corresponding author, which is the author that is corresponding with the medical journal, and the keywords, which are the main words, or they're comparable to hashtags from our everyday life now. So they are the highlights of the research that you have conducted, and they are used to search. If you go into PubMed, for example, you're interested in a specific topic, you would use it as a keyword, like smoking or CA stomach or something like that, that can highlight your work. Also, the title page will include the list of abbreviations that you have used in your writing, because you need to make it clear for the reader who is not aware of your topic, or and they want to understand what these abbreviations stand for. Next, please. Okay, so here's an example of a title page. This is part of publication, of course. As you can see, the first part where it says the title, it says association between NBS1 polymorphism haplotype and smoking-related cancer sites. So this is our title. It has the words explaining what the research relationship is trying to examine. And under that, we have the authors, the names, and we can see there are different authors, and we have after that their affiliations. So if you can see, the first author has 1 at the end of its name, and if you go back to the affiliation, you will see the Department of Epidemiology, University of California. This is an example, so you can know the affiliation of the author and other authors. Next, please. Okay, this is also examples. If you can see at top, there's correspondence to the corresponding authors, which it has their name, their address, and contact information. So because they're the one corresponding, and below that are the keywords, which, like we mentioned, they're the highlights that will show what your research is about, and also we can search for different articles with these. And the running title and the abbreviations used, for example, OR for odds ratio, so the reader can know what you're exactly referring to. Next, please. So we talked about the title page, the affiliations, and now we're going forward to the abstract part. Next, please. So the abstract is actually a summary of your manuscript. You can say a mini manuscript, but it's very important, and the importance comes from that it's the most readable section, because it's a summary, most readers are encouraged to read it first, and then based on that, they will decide if they're interested to go and read the whole article. So it allows a quick scan for a large scientific literature, and then they would take a decision if they want to go in depth. That's why the abstract should be a little less technical than the article itself, and it should be short, to 200, maybe 300 words. This would depend on the journal preferences or requirements. But generally, your abstract will be your way to the capturing the readers to your journal. Next, please. Okay, so like we said, the abstract will open the road for your article to get into the way of publication, but bear in mind that the publication procedure is lengthy. It can take up to a year because the author would submit it, and then from the journal side, an editor will be assigned to read your manuscripts, and they will assign reviewers to review it, to inspect it. And then the reviewers will decide, based on their review of abstract, if they want to review the paper. So several reviewers will inspect and edit and send it back to you, and they will have some questions maybe till they get the level of acceptance. And if accepted, the editor will send back the papers to the authors along with their revisions, and the author will revise it, send it back. There could be a possibility of a second review anyway. But hopefully, when all the reviews are done in consensus, then this will lead to the publication. Next, please. Okay, so when writing your abstract, you have the choice, either if you want to write it structured, meaning that you divide it into sections, like having a different section for the objective and the setting, you talk about the participant, or you have the other option of writing it in unstructured way, like you are writing a piece of a storytelling maybe, where you put everything together in one big paragraph. Next, please. Okay, so now we'll be moving to the introduction part. Okay, so the introduction is meant to summarize the existing body of literature in regards to the topic of interest that you're researching. It should highlight the relevant literature so the reader can understand where your interest comes from and why you conducted this research and what you are hoping to do. So it should always have information about the background, the rationale, and also the objectives of your research, and also the review of different literature, and briefly stating the methods that you used in your investigation. Next, please. Okay, so after the introduction or the background, we'll move on to the materials and methods element of your manuscript. So in this part, you will be telling your reader about the study type or design. For example, if you're conducting a cross-sectional study or case control or cohort or any type. And also you will explain about the setting of your research. For example, you will talk about the geographical location where you conducted research, the relevant dates or the period of the recruitment. You will talk about the exposure and the follow-up and the data collection settings. And also a very important part, of course, is the participants part. You have to talk here about the eligibility criteria that you chose your participants upon, your methods of selection. For example, if you're conducting a case control study, how did you do the case ascertainment? How did you select your controls? And what was the rationale for the case control choice? For example, if you're doing a cohort study, what are your methods for follow-up, and etc. Next, please. Okay, so also in the materials and methods sections, you have to write about the different variables you used. For example, if your research contains an age variable that divide the sample size into different groups, you have to explain it here. Also, you talk about the data sources and measurement. For example, if let's say you did a cross-sectional study and you distributed questionnaires, so this is something that you have to write about here. Or if you're getting a clinical sort of measurement, also you have to talk about. I'm sorry, my daughter is trying to participate in my presentation. So if you have different type of bias that you think have affected the study somehow, it's important to mention them. And of course, your study size, you'll describe it and mention if you did any stratification of any sort of sub-level divisions. Next, please. So this is an example of how the materials and methods section is written. Sorry, if you can press again, please, on the slide so it can highlight the areas. Yes, so here we can see the study size, the cancer cases, N equals 611. So N refers to the study size. And the recruitment rates. Recruitment rates were 39%, for example, for eligible lung cancer, and 46% for eligible UADTI cancer cases. And down there, we can see the IRB review, the institutional review board information, which is also a very important part to be mentioned in the materials and methods. Next, please. Yeah, so there's another one about the data collection. Thank you. The methods used for the data collection and, for example, the demographic factors, the personal habits, or cigarette smoking, passive smoking, things like that. Next, please. So, statistical methods, as part of your manuscript, should explain how variables were handled. For example, categorical. So if they were such factors, how did you categorize them? You have to explain it here. You have to describe all the statistical methods. For example, how you controlled for confounding, or if you did stratified analysis, how did you do it and what happened in the interactions, or sensitivity analyses, for example. Also, there could be a study-specific factors. For example, if you're conducting a cross-sectional study, you would want to mention the analytical methods that you use to account for sampling strategies. And if you, let's say, conducted a case control study, you have to also explain to your readers how the cases and the controls were matched, if applicable. And another example, if you're conducting a cohort study, you have to explain to your reader how you manage the loss to follow up or how you address it if it existed. Next, please. So, thank you. Yes, so in the statistical analysis, as we can see in this paper, here's an example where adjustment of variables took place. So you can see, for example, adjustment happened for age, gender, ethnicity, educational control, and for example, the age was adjusted in 5 categories. So it shows you the categories. For example, the age was divided into 5-year groups, or to group less than 34, between 35, 36, and such adjustments. Also, the statistical methods used or models, sorry, they should be mentioned, such as logistic regression or any other type of methods. Next, please. Okay, so now I would leave the floor for my colleague, Dr. Abdelwahab, to finish the rest of the presentation on our manuscript writing.
Okay, thank you, Dr. Suhir. Hello, everyone. I'm Dr. Abdelwahab Ahmed, and I'm going to complete the presentation. Next slide, please. Okay, so now about the, we are going to talk about the section of the results. When you are writing your results, you can write it in paragraph format, which is a summary of your main findings presented in the forms of tables and figures. Also, results not presented in tables or figures can also be mentioned in this section. And if this is the first time to present information regarding the study, one may want to present numbers of individuals at each stage of the study, so they can be clear for the readers. This section of results should also include characteristics of study participants, and this is usually done in the first table, like what are they, males or females, and what is their ethnicity. So also it should include a number of missing main results, and the main results are usually presented in the second table, and additional analysis such as stratified analysis, effect modification, interactions, sensitivity analysis, and these are written in the additional tables. Next, please. This is table 1, which is contain the baseline characteristics of the participants, their age, ethnicity, are they perimenopausal or postmenopausal, and stuffs like that. Next, please. The second table, which contain the main results of the study. Next table, please. And this is example of the table 3, which contains additional informations about the study, like effect modification and confounding. And the next slide, please. This is another additional table. Okay, next slide. More tables comparing the different results of the study. Next, please. So the tables and figures. These tables and figures should be after the discussion or the reference section, and they should stand alone, and they should be about 6 tables at maximum. Sometimes this depends on the journal, and it must be you must use a consistent footnoting style, and these footnotes may be specific to the journals. Each journal has its styles and in writing the articles, and you should be consistent with what the journal wants. Then you should define the abbreviations, even if they have been defined in the manuscript. These abbreviations in the tables, you should also here clarify what they are standing for. Next, please. Okay, now we are going to talk about the section of discussion. In the discussion, this is your moment to shine and show your knowledge of the prior literature You must summarize key results in reference to study objectives, and you must interpret your study and talk more about it and clarify the informations in it. And also, you must mention the significance of your paper. Next, please. In the discussion section, also, you should mention the limitations of the study and the study findings. Like if your study have potential bias, and if there are any tools which you must use and you didn't use. But when whenever discussing your limitations, try to put a positive spin on what you have to say. Like you, after mentioning your limitations, you must say something that is a positive words about it. So the limitations will not affect the study strengths. For example, measures of height and weight were self-reported, likely resulting in non-differential misclassification. Nonetheless, such misclassification was not an important cause of concern, as some found self-reported height and weight to be reasonably accurate. So you mentioned the limitation, but you have mentioned the positive spin on it. So in the discussion part also, you should mention the conclusions of your study. Conclusions about the future directions of your study, potential health, public health implications. Next, please. Okay, after this section, the next section in your manuscript will be acknowledgements and funding. Acknowledgements and funding. Here in this section, you will list funding sources for the study and authors. You are going also to thank the participants of the study for their time, commitment, and participation. After that, we come to the section of references. Reference section. This is the most section which depends on the style of journal in writing articles. So in writing your references, you can use products like ProCite, Reference Manager, or EndNote for citations. Order of reference can be presented in alphabetical order or by order of presentation. And the formatting for a specific journal can be done using one of these programs. Many programs have the journal styles preset. However, always check to make sure the formatting is done correctly. Sometimes the journal's information may have been imported incorrectly, or the journal format style may be different than the one in the program. So these programs will help you in writing your the reference section. Then after that, I would like to give you general rules for writing the manuscript. You must spell check, try to avoid errors in typing. You must also use correct and standard nomenclature. When using abbreviations, always define the abbreviations the first time they are used. For example, our air digestive tract, UADT. Your writing also must be consistent, and you must number your pages so that it's clear to follow your manuscript page. And a final advice after finishing our talking about the manuscript, always rewrite your manuscript and proofread your work. So you have also to check all your numbers for accuracy and consistency, so that you can give your best in writing your manuscript. Okay, next page. So after you write your manuscript, what's next? Then you must decide that whether you want to publish and submit your paper or not. And after that, what do you want to publish? Do you want to publish the abstract or the full report? And then you have to choose your forum, which type of journal is best for you, what audience are you targeting. And then after deciding that, you research for the journal, for information about the journal you want to publish in it, and to know what are the publication guidelines and what is article style according to this journal. Next, please. After submission, let's talk about the publication procedure. Usually the publication procedure takes about 6 months to 12 months. And the first step is that authors submit. After that, editor is assigned to the manuscript. Then editors assign reviewers, which are associated editors to inspect. Then the reviewers will decide whether to review paper. Then several reviewers inspect and edit. Editor decides on accuracy of revision and whether to accept paper. Then if it were accepted, editor sends paper back to author with revisions, and then the author revises paper and sends it back. And there will be a possibility of second review process. And after you send it your paper back to the editors, then it can be published. So now you have your publication. Next, please. We have finished our presentation of about manuscript writing, the scientific manuscript. So here are some useful resources that you can use for more reading about scientific manuscript writing and the steps which you should follow to write each section in the manuscript. Next, please. Here are additional resources and links to know more about the writing. Thank you.
Thank you so much, Dr. Suhir and Dr. Abdelwahab, for this very informative presentation. So any comments or questions?
Thank you so much. It's excellent presentation. Thanks.
So our last topic for today is how to start writing your personal statement, presented by Dr. Proma. Dr. Proma, the stage is yours.
Hello everyone, good afternoon. Can everyone hear me?
Yes, we can.
Let me share my screen. Okay, so today I will share my knowledge about how to write a personal statement for ERAS application. Thank you, Dr. Amal, for giving me opportunity to present this topic.
You're welcome.
Okay. First of all, what's a personal statement? So basically, it's a formal way to present your story in a concise manner. Here you can share your personal story, your personal characteristic, your personal struggle to the programs before meeting them in person. And now comes what is the purpose of it. It is the opportunity to introduce yourself to the residency program directors and highlight the qualification, the experiences, and your aspirations. And here you can demonstrate your passion for medicine. You can showcase your unique qualities that make you a strong candidate. By the recommendation letters, program can sense your personality and interest. However, you are the best person to include the meaningful details that are not in the CV. What should be the word count of a personal statement? The recommended word count is within 600 to 700 words, and it shouldn't be more than 1 page. Now comes about the structure. Basically, it has 3 main parts. First of all, introduction and subsequent body paragraphs, and finally the conclusion. We should work on the body paragraphs first and then write the introduction and conclusion to tie relation between them. In the introduction, we should begin with a catchy, attention-grabbing opening. And here we should clearly state our interest in the specific residency program and capture the reader's attention. We can share our motivation for pursuing a medical residency and briefly outline the main point that's going to be detailed in this detailed discussion in the body paragraphs. In the subsequent body paragraphs, expand the main point you have mentioned in the introduction. Provide specific example that illustrate your experiences, skills, and qualities. You can discuss the patient encounters you have in your medical school or in the intern year in the rotations. And also you can discuss about the research project if you have any leadership experience or any other notable achievement. You can highlight how these experiences have contributed to your personal and professional growth and shaped your aspiration for the residency. In the conclusion, you can summarize your personal statement, emphasize your commitment to the field of medicine and your desire to contribute to patient care. You can reflect on the impact you hope to make as a resident and beyond. Okay, so before starting writing, everyone thinks that what should be written. So here is some brainstorming questions that you can answer yourselves and start writing. Like, first of all, what first drew you to medicine? You can tell about any specific event that you're interested and drew you to the medicine. And also you can share any experience, clinical or otherwise, that has a significant impact on you. And if you are choosing a specialty like internal medicine, family medicine, you can like say why that specialty and why are you a fit for that specialty. And if you have any red flag or anything major that need to be addressed, you can mention it here, but remember that do not mention if you don't have any valid or meaningful explanation for that. You can discuss it in your interview also. And why you are choosing that specific program, and why do you think you are the best fit for that specific program? And what are your most meaningful extracurricular activities and why? And what's an accomplishment you are most proud of? You can think about the answers and start your writing. And some tips about writing. First of all, you should be genuine and authentic and write it in your own voice and be true to yourself. Avoid using any cliche or generic statement. Instead, provide specific detail and personal narrative to showcase your unique perspective and experiences. And you should show, don't just tell. Instead, simply stating your quality and accomplishment. Use descriptive language to show how you embody this quality. Use concrete example and storytelling technique to engage the reader. Just if you say like, I'm a hardworking person or I'm a reliable person, not only just mention, you should also mention a story that why you are hardworking and why you are a reliable person. And tailor your statement to the specific program you are applying to. Before that, you should research the specific program's value, mission, and objective, and explain how your interest is aligning with theirs. And be professional, maintain a professional tone throughout your personal statement. Avoid any humor or controversial topic that maybe sounds inappropriate. So now comes when you should start in the personal statement writing. The best answer is as early as possible. you should start writing within May, June, and within June, July. In between, you can write multiple drafts and editing multiple times. Also, you can check the grammar and plagiarism, obviously. And within August, you should have a final draft ready. As you are going to apply for residency within September, within August, the final draft should be ready. Some do's, like start early and review it several times, and unite your essay around the central topic, linking it to your planned specialty. Get help from others. You can show your personal statement to your fellow colleagues or any seniors or your mentors, or if you have any native American friend, native English speaking friend, you can also get help from there. And you can get help from multiple person, because multiple person have multiple point of view. You can get them and like edit your personal statement. You can provide your specific narrative, for example, and mention what you learned in your clinical rotation that have influenced your decision becoming a resident in USA. And finally, use perfect grammar, spelling, and punctuation. You can use Grammarly to check your grammar. It's a very useful tool. And the thing you shouldn't do during writing a personal statement, never submit a generic personal statement that everyone is going to submit, because your personal statement should be like unique to yours. And don't try to be overly creative. Also, don't try to be too much humble. You should try to find a fine line between these two. And mainly focus on your clinical year. Don't over focus in your preclinical year. Don't over-mention stuff that's already in your CV unless you're trying to make a point. And finally, don't plagiarize. Don't ever do any plagiarism. Remember, the personal statement is your opportunity to showcase your strength, experience, and aspiration to residency program director. It should be a well-crafted, authentic reflection of your journey and why you are a strong candidate for their program. And basically, like we all think that we don't have any story to tell and our story are not worth telling, but remember one thing, you just have to learn how to tell it better. And the major component of this journey is to appreciate your journey first, because when you are going to believe your own story, then you can make someone else believe in it. Thank you. If anyone have any comments or any suggestion, feel free to say that.
Thank you so much. This is also.
Thank you so much, Dr. Nadir.
You can show one point screen. So the previous the fellows, they touched and they shared their personal statements, for example, for you. So I shared a link from the chat. So if you want to look at that whenever you have time, there are some personal statements made by fellows who managed to either residency or fellowship, and also they put or share the GitHub application. So if you want to go there, you will find some samples. You can see all the list, and hopefully this will help some of you and get an idea and some examples. Thank you.
Thank you so much, Dr. Nadir, for sharing. Thank you, Dr. Proma, for the great presentation. The last section for today's meeting is the project updates.
Hello, Dr. Nadir. I have a new project to discuss. If you guys allow me to share my screen.
Go ahead.
Can you guys see it?
Yes, yes, we can see.
Good afternoon, everybody. Welcome to my presentation, or should I call it my proposal for a new application. So this application is going to be about oncology. Is going to be about bridging the gap between radiation and medical oncology for optimal patient outcomes. Let's start by the introduction. In this presentation, we will explore an application designed for diagnosis and treatment of cancer. So this application is gonna be about cancer, about diagnosis and treatment, and about everything cancer related. Cancer is a complex and devastating disease that affects millions of lives worldwide. The need for accurate and efficient tools to aid in cancer diagnosis, treatment selection, and monitoring is important. Cancer treatment often involves a combination of radiation therapy and systemic therapies, such as chemotherapy and targeted therapies. However, coordinating these two treatment modalities and ensuring their optimal synergy can be complex. So here we're going to talk about radiation oncology. I'm just going to give you a general overview about radiation oncology and medical oncology. So in radiation oncology, we utilize various techniques such as external beam radiation therapy, which is here. This is the linear accelerator, which is just we give external beam to treat cancers. We have also another technique called brachytherapy, which involve inserting a radioactive source inside a patient's body. We also have something called stereotactic radiosurgery, which is just highly focused energy beam to the brain. We usually use it for small brain tumors or maybe AV malformation and other stuff. So the main aim of radiation oncology is zapping the cancer cell and minimizing damage to surrounding tissue. Radiation oncology can be used as a primary treatment modality, or it can be adjuvant therapy following surgery or systemic treatment. Or we can use it as a palliative care treatment, which is just we give highly doses over a short period of time and less sessions. And those, of course, for advanced cancer cases. Medical oncology, on the other hand, encompasses the diagnosis, treatment, and management of various types of cancer using systemic therapies. This includes chemotherapy. We also use immunotherapy, which is a very promising treatment. As we all know, like in the past couple of years, immunotherapy has gained traction and is being used more and more, as it proving more effective against cancer. So here we have overview of oncology. So oncologists can be medical oncology, which is usually which is a fellowship after internal medicine. So you do internal medicine, which is 3 years, and then 3 years of fellowship in hematology oncology. Some program offer 2 years of separated oncology fellowship. We also have surgical oncology. Surgical oncology is a fellowship after general surgery. General surgery is 5 years. Then you do a fellowship, which is usually 3 years. Then we have, at last, we have radiation oncologist. It's a 4-year of dedicated residency. You do 1 year of any ACGME accredited residency. It can be in surgery or medicine or pediatrics. Then you do 4 year of dedicated residency. But the main oncologist for patient is usually the medical oncologist. So in the application, we're gonna focus on diagnosis, which can be from the pathological side, which is the staging. It can be radiology too. Then we have the workup. Here we have the NCCN guidelines, which is the National Cancer Comprehensive Network. They give guidelines. It's very updated. It's like they update it every couple of months. So we're gonna try to use that. You have diagnosis, you have workup, and then we're gonna have the treatment here. This is just another example of treatment. We're gonna try to try to write a treatment from the surgical side and the medical side and the radiation side. This is another one. This is the NCCN guideline for prostate cancer. As you can see here, the initial therapy, you have the adjuvant therapy, and they give you the guidelines. Then we're gonna try to do another section, which is the contouring atlases. This is basically where we we draw the target of the tumor. So we have a website. It's an interactive website that tells you the organ at risk. I can explain it better here. So here you have the organ at risk, which is, say for example, like we're trying to treat the lung cancer with radiation. You have the organ at risk, which is I mean the breast, and we have the lungs here at risk. So we have here the body, we have the heart here, we have the lung is supposed to be here. And here we have the targets. The targets is just the tumor volume. So we have the clinical tumor volume, which is here, and you have the GTV and PTV, which is the gross tumor volume, and you have the P, which is the here tumor volume. In another section, we're gonna try to discuss cancer in specific populations. We're gonna try to discuss geriatric oncology. We're gonna focus on the unique needs of older adults with cancer. Comes with specific challenges that need to be addressed for optimal care. Some of the challenges in geriatric include age-related physiological changes, comorbidities and polypharmacy, frailty and functional decline, and cognitive impairment and decision-making capacity. We have the psychosocial considerations and their presentation in clinical trials, and palliative and end-of-life care consideration discussing. This is the first topic. This is the first specific population. The second specific population is going to be adolescent and young adult oncology. And the third population is going to be cancer in people with HIV. Then we're going to add another section, which is the important calculators. We're going to try to put some of them, like not a lot of them, but we're going to try to put the most important calculators. We have MU, which is the monitor unit. We're going to try to put the tumor volume calculator, and we have the cumulative dose tolerance, and many more. The specialties involved, radiation oncology is going to include hematology oncology, is going to include surgical oncology, It's going to include radiology too. It's going to include pathology. I didn't mention this in the slide, but we're going to try to put the staging of each cancer. It's going to include pediatrics too and geriatrics. We have multiple resources we're gonna use. First, we're gonna use the National Comprehensive Cancer Network, which is the gold standard, and a bunch of textbooks. We're gonna use the eContour website for contouring. I don't know if we're gonna be able to incorporate this into our application, but we'll try, and possibly other resources if needed. This is our team. We have here Dr. Nadir, the supervisor, and then we split ourselves into teams. We have teams handling the radiation oncology part. We have teams handling the pediatric oncology. We have a team for clinical oncology, and we have a team for diagnostic radiology and a team for pathology. Thank you guys for listening, and if anyone has any question or suggestion, please let me know. Thank you.
Thank you so much. This is really great work and great idea. So thanks for presenting this, and thank you the whole team.
Thank you.
Yeah. So
I just have one question, Dr. Nadir.
Yes, go ahead.
We're here in the resources. The textbooks is paid, is for profit. So my question is, can we use it without taking permission from them, or do we need to?
I think we need to take permission. So when you want to get any information, you should contact them and see, explain the product. We are doing this as free or as paid. So if it's paid, they will give you hotline. But if it's free, then they may be handling it softly, and they may just limit certain things that they benefit from. So they don't want to give it to you so that you can give it others for free, something like that. So,
Okay, so I should just send them emails and take their permission?
Okay,
so, thank you.
But before we, I think, I think the concept is great. My approach is like the approach in geriatric. Usually we go, we start with low and then we go slow. So you started very good with dividing the aspects into teams. So each team will work on a certain aspect, and the idea is, when you have the product, you think ahead, who's the user? Is it medical doctors or providers in the field, or patients and family? So who is gonna download the app? Who is gonna use it? So if you have a good idea about that, that will make developing the app much easier. Number one. Number two, if you have this clear, some of the new approaches is to involve some of these users. So let's say you want to get it to radiologists. Then if you have some radiologists, even if they are in the residency, first year, second year, so that you can get their input as users. So when the user asks, they can tell you, hey, we use this a lot, why don't you add it? Or we don't use this, so you move it, something like that. Or if it's for patients, you may add it, add some of the patients in the teams so that they can have their input. They will tell you, yeah, we find it useful to do this or add this, or maybe it's not useful for us, something like that. So instead of investing all the energy and producing a product that the user will not use, it's not going to be good for you, it's going to be waste. But when you have the input from the other side, or at least you have an idea who is going to use the app, that would be great. But thank you. So it's a good idea.
Thank you, Dr. Nadi. And so the target is going to be like residents and medical students.
Perfect. Yes.
Thank you.
So if you want to approach or reach out for some of the students who are interested in these areas, maybe, and add them to some of the teams, that would be great, as well as if you have some, or the team has some access to some of the residents that can also contribute or like can put or share their input, that would be great.
Thank you.
Good. Excellent. Good work. Awesome. Anybody else? Any updates?
Hello, Dr. Nader. So regarding the Arabic version for the INR Guard app, so we expect that in the next few days, we have all videos from the video maker that we we asked him to do the videos for us. So he provided us with one of the videos. It looks very great. So we are very excited to show you the final product, maybe in a week. Yeah.
Excellent. Excellent. Good job. Thanks for
Thank
that.
you.
You're welcome. Anyone else?
Good afternoon, Dr. Nader.
Good afternoon. Go ahead.
Yes, so just would like to update you in our blood pressure app. So today we just did the first meeting. We kind of just set up, guidance about what we're gonna do, the platform that we're gonna use, and kind of like the task that we put in our mind in order to be divided between the participants. So just letting you know that we started, and I will show you. I'll share with you the email, inshallah, the presentation that we did regarding, our guidelines regarding the app.
Excellent. Great. Thank you so much for sharing.
You're welcome.
Anyone else? I know Rafeeda Saleh also has an idea about developing the app in neurology, epilepsy. So that's a good idea as well. Anyone else?
Hello.
Hey, Rafeeda, go ahead.
Good evening, everyone. I hope you're having a good day. So yes, I do have this epilepsy app idea, and I'm hoping to build a team within the coming days soon, and I hope it goes well, inshallah.
Great, great. Thank you. Excellent idea. Okay.
Thank you.
You're welcome. So if you have other ideas, please share. You can contact me on email, and text, or you can call. The other ideas about abstract or about manuscript you can discuss as well in the future. There are some conferences where they have deadlines. One of them is NAPCRET. It's like for primary care physicians in the US and in Canada. And we presented some of our work in the past about this fellowship. So they have a deadline, I think, in June, July. So we can work on some of ideas about the education part. Maybe you can create some topics out of their previous work. You can access their abstracts from the past few years and look at other people, how did they present their ideas on their topics. And we can apply the same in this program. So we can work on identifying areas that we can share with the group and show them that it's an important aspect to look at the research part pertaining to population in need. In our group, we focus on geriatric, but not necessarily excluding other areas of population. So we can work on presenting wherever we are working on. There are two types. One of them is projects in progress, and the other one is completed project. So you don't have to share all the things. If you have a project, you can just share the idea and how you are doing the methods to collect your data. And then maybe next year you can present, or someone else from the group can present the whole topic. This is what we did. So the first year we talk about the idea about developing this program, and they accepted that. And then next second year we presented how did the first cohort or the first batch, how did they learn, and what kind of results we had. So it's interesting. I know there are other societies that are accepting also proposal, or they will be accepting proposals for abstract, and we can work on that as well. Just for your information. Any other questions? Any other comments? Any other updates? I'd like to thank all the presenters from today. You did great, all of you. Thank you so much, and thank you, Dr. Ahmed, for leading the meeting. Thank you, everyone who attended, and I wish you all the best. Have a wonderful day. Have a wonderful night, wherever you are, and we'll see you next week. Thank you.
Thank you, Dr.
Thank you, Dr. Nader.
Thank you, Dr. Nader.
Thank you, Dr. Nader.
Thank you so much.
Thank you, Dr. Nader. Have a good one.
Have a great one.
Thank you, Dr. Nader. Have a great day.
Thank you.
Thank you, Dr. Nader.
Thank you. Have a good one.
Thank you, Dr. Nader.
Thank you, Nadia. Yeah, Nadia.
Thank you.
Thanks. Bye.
Thank you, Dr. Nader.
Thank you so much, Dr. Nader.
Thank you so much. And great work, and thank you as always. Have a wonderful day.
You're welcome. Thank you. It was a great opportunity. My first time leading, but was great.
Yeah. You're gonna teach us how to do that.
Maybe.
Thank you so much. Have a wonderful day. Bye-bye. Assalamu alaikum.
I hope you have a great day.
Thank you so much, Dr.